Hello, I am Dr. Williams and I will be lecturing on innate immunity and wound healing. This lecture is an introduction to the pathophysiology of innate immunity and should be used to complement your readings in your textbooks. To assist you with your retention of this content, I have divided this lecture into several short PowerPoint presentations. This strategy is aimed to assist you with being able to organize the enormous amount of content into smaller, manageable sections. The sections will be as follows: innate immunity, adaptive immunity, alterations in immunity, and then you will have a lecture on HIV. Hopefully, by delivering the content in this manner, you will be able to study the content along with your textbooks and be able to retain the information. Let's get started. So let's get started. The objectives for this lecture is as follows. I'm not going to read them to you, but I do want you to know that we're going to be looking at different sections. Although the immune system kind of works together, we're going to kind of break it down into sections. We'll first talk globally about what is the defense mechanisms that exist. Then we will break it down to first line defense, second, and then third. We will then look at what goes on in the inflammation process, both locally and systematically. Then we will look at inflammation from the acute versus the chronic. And then we will conclude this lecture talking about the phases of wound healing. So we're going to go ahead and get started. So now that I've explained how the lectures will be presented and you kind of understand the framework of these lectures, let's start to talk about the content related to immunity. There are two types of immunity that we are going to be discussing: innate resistance or immunity and adaptive. In this lecture, we're going to focus on the innate. The innate immunity, we're talking about first and second line defense of immunity. The first line of defense, which is probably a review for you, is what we call the natural barriers. Whereas the second line is the inflammatory response. And we are going to speak a lot more about the difference between the first line, our natural barriers, and our second line, which is inflammation. And in the next lecture, we will talk about adaptive, which is the third line of defense. When talking about the first line of defense, it is important to remember that there are some natural barriers that exist to help our immune system. These natural barriers consist of things like the physical barriers, the mechanical barriers, and the biochemical barriers. Our physical barriers, as you can kind of relate, is when we talk about things like the skin. Or we also talk about the linings in our GI tract, our GU tract, and our respiratory tract. And the ability of our body to help remove some of these microorganisms if they get into any of these areas, such as our nasal passages, our lungs, and even our GI tract. And this can be done through things such as washing, vomiting, urinating. So now that we've talked about physical and mechanical barriers, I would like to take some time and talk about biochemical barriers. When you're thinking about biochemical barriers in the immune system, I want you to think about three biochemical mechanisms. The first one is the ability of the body to synthesize and secrete substances to trap and destroy microorganisms. The second is the antimicrobial peptides. And the third is the normal microbiome. I am going to give you an example of each one of these. So the first one, let's talk about the synthesization and secretion of substances that trap and destroy microorganisms. I want you to think about the ability of the human body to perspire, create tears or saliva. And how does that work in the immune system? It works because those substances contain an enzyme called lysosomes. These lysosomes attack the cell walls of the gram-positive bacteria, and that attack results in a very acidic skin surface of a pH about 3 to 5. And because of that, it makes the environment basically unlivable for most bacteria. So that's one way that we synthesize and secrete substances that help our immune system. Another way is when we think about the sebaceous glands that we have. The skin secretes an antibacterial and antifungal fatty acids and lactic acids. So that's another way that it is one of our barriers in our immune system, right? And then finally, when it comes down to this, we think about our epithelial cells. And the epithelial cells secretes a very complex array of proteins. And these complex array of proteins can be divided into two classes, cathelicidins and deficins. These two classes of amino acids are toxic to several types of bacteria, fungi, and viruses. So it is important to know when we talk about the cathelicidins, they are actually stored in our mast cells, the neutrophils, and a variety of our epithelial cells, right? And then we have the deficins. They actually come in both alpha and beta. So the alpha deficins are rich in granules and neutrophils, and they contribute to killing of those cells. And you can find those in the Paneth cells, which line the small intestines. Those are our alpha deficins. So they're in the Paneth cells that line the small intestines. Whereas the beta deficins, they are found in the epithelial cells lining the respiratory tract, the urinary tract, and the intestinal tract, and on the skin. And what they do is they help to protect the epithelial surface even against HIV as well. So the alpha deficins, what we know is they are found in the small intestines, and they're in the Paneth cells in the small intestines. And then we have the beta deficins. Those are located in the respiratory, the lining of the respiratory, the urinary, intestinal, and skin. But the beta deficins is also very helpful in protecting the epithelial surface against HIV. It is important to know that both the alpha deficins and the beta deficins, they can be activated in both the innate and adaptive immunity. We're going to talk about adaptive immunity in the next lecture, but it's very important to know that they can be activated in both of those, okay? So then let's talk a little bit about the normal microbiome, the third biochemical barrier. Now, what we know is the microbiome is kind of like this commensal relationship that occurs in our body. And what that means is we know that there are bacteria that exist in the body, but they don't cause any complications because it actually has a benefit, right? And so it doesn't affect the other organism because it benefits the organism. But microbiomes also can be mutualistic. And what that means is both organisms benefit, right? And so how does that happen? What we know about the natural biome, they can produce chemicals, and those chemicals can inhibit the colonization of pathogenic organisms. So they produce these chemicals that prevent the overproduction of pathogenic microorganisms. The chemicals that they usually produce are chemicals such as ammonia, phenols, and indoles, and other type of toxics. Now, it is important to note, just think about the vaginal system. And what we know about the vagina is that there are about 22 different species of lactobacillus, right, that have been identified in the vaginal microbiome. There's 4 that are predominant, but there's about 22 different species. And what this lactobacillus does is it produces hydrogen peroxide, lactic acidosis, and evobacteriacins. And the production of these chemicals helps to prevent infection. But this only is appropriate or beneficial if everything stays in a unified or a organized and kind of a balanced manner. If it becomes unbalanced, then we know that we can get infection. So it is important to note that there is a natural microbiome that exists, and it needs to exist in a certain level. And if it doesn't exist in that level or a balance, then we can then get infection. However, not all bacteria are always negative. So it's important to note that, just to summarize, when we're talking about the first line of defense, that there is physical barriers, there is mechanical barriers, and there are biochemical barriers. And then you can break those down into the specifics on each one of those. Now, what is very important to kind of think of as you're trying to, if you're doing an algorithm in your mind about immunity, think that we have a first line of defense, and then we have these barriers that help us to keep that first line of defense. However, there can be a break in the integrity of the first line of defense. If that happens, if there is a compromise in any manner, our body, our immune system goes into the second line of defense, which is needed. So let's go into talking about the second line of defense, which is inflammation. Now let's talk about the second line of defense, the inflammation response. I think it's important to note that when we're talking about the inflammation response, the second line of defense, this is a response because the first line of defense has been breached. It is also a response that occurs as the result of cellular tissue damage. Inflammation is a rapid initiation and interactive system. There are 4 things or 4 purposes for the inflammation response. The first one is that the inflammation response is designed to limit the extent of tissue damage that has occurred, if any. Second is to destroy any contaminating infectious microorganisms. And third is to initiate adaptive immune responses. And fourth and finally is to begin the healing process. When looking at the inflammatory response that occurs, it is important to note that there are many different types of injuries that can activate the inflammation process. Injuries such as necrosis, we have trauma, there can be a chemical injury, there can be foreign bodies, and even extreme temperatures. With that, any of those injuries, we often see in the acute phase some classic symptoms. These classic symptoms, also known as cardinal signs, consist of redness, heat, swelling, pain, and loss of function. And once that occurs, we see those symptoms. However, there is an actual vascular response that is occurring. When we talk about the vascular response, there are 3 characteristic changes that are occurring within the arterioles, capillaries, and the venules. And this is all happening near the site of infection. Now let's discuss the reactions that occur in blood vessels during acute inflammation. There are 2 distinct changes that occur in the blood vessels. The first is there is a change in the vascular flow and caliber. The second is that there is increased vascular permeability, also known as vascular leakage. So let's talk a little more about what occurs during these changes. I'd like to start with the change of the vascular flow in caliber. The way I remember what occurs during vascular flow and caliber is kind of like in 4 steps. The first is that we have vascular dilatation, and this happens early in acute inflammation. And it occurs because we get histamine and nitric oxide, and it actually works on the vascular smooth muscle. And this causes an increased blood flow, which we see is evident clinically by the heat and redness, the erythema that we see at the site of the inflammation. The second thing we see when it comes down to vascular flow and caliber is we have increased permeability of the microvasculature. And with this increased permeability, we get an outpouring of protein-rich fluid into the extravascular tissue. And the next step that we see is this now leads to loss of fluid and increased vascular diameter. And because of this gives us the blood flows slower, and we get a more concentration of the red blood cells in the small vessels, and thus increased viscosity of the blood. And the last step that we see is that we get the blood stasis. And this is where we have the neutrophils also start to accumulate at the vascular endothelium. So when we think about the vascular flow and caliber, I want you to think about these 4 steps: the vasodilatation, the increased permeability at the vasculature, we have the loss of fluid, which causes an increase of the vessel diameter, and then finally we get that blood stasis, and we get those neutrophils that start to accumulate at the vascular endothelium. And so now let's talk about the second change that we see within the vasculature, which is called the increased vascular permeability, or also the vascular leakage. Now, during increased vascular permeability, we get the escape of our protein-rich exudate. And so the stages that I see that occur with this is that first we get the contraction of the endothelium. And this contraction results in increased epithelial space. Next, we get endothelial injury, which results in the necrosis and the detachment. And the final step is the transcytosis, which is an increase in the transport of fluid and proteins through the endothelial cells. So when you're thinking about the changes that we get during in the blood vessels during acute inflammation, I want you to think about these 2 distinct stages or changes that happen, which is the vascular flow and caliber, and then we have the increased vascular permeability and the leakage. And then you put the details in there. If you need to get a little more clarity, please refer to your book about further details on what the specifics are that occur during this process. So now let's talk about the plasma protein systems. There are 3 plasma protein systems that provide a biochemical barrier against invading pathogens. These systems consist of the complement system, the clotting system, and the kinin system. Each one of these systems, although they're separate systems, are all contain inactive enzymes known as proenzymes. In order to be an effective part of the inflammatory response, the proenzymes must be activated to help in the inflammation process. That activation occurs when we have these larger fragments that are cut by these enzymes that activate them. The larger fragments will then continue to activate the system, and we refer to that as a cascade. So each one of these systems will then go from just a complement system to like the complement cascade, the clotting cascade, and the kinin cascade. So as these enzymes activate the system, the larger enzymes will continue to activate while the smaller enzymes will contribute to the inflammation process, which actually promotes the inflammation. So let's talk a little bit more specifically about the plasma protein systems. And when we're talking about the plasma protein system, the one I would like to start off with first is the complement system. The complement system has three pathways in which it can be activated: the classical, the lecithin, and the alternative. When we're talking about the classical, we're talking about a pathway that is primarily activated by the antibodies. There has to be a combining of the antibody to an antigen on at least, and it has to bind with at least two of the receptors on the antigen. Once we have that binding, we have a production of C1 enzyme. That initiation of the C1 enzyme then leads to further production of the enzymes C3 and C5. And once we have that, then those enzymes are produced, we can then have the initiation of the inflammation process. That is our classical. Then when you think about the lecithin pathway, it's similar to the classical, but it is dependent on the antigen, not the antibody. And it's activated primarily by MBL, or the mannose containing bacterial carbohydrates. And once that is activated, again, it will then create the C1 that will bind to the endotoxins that can chain the carbohydrate mannose. Once it binds to that endotoxin, then what it can then start is the inflammation process. Now, the third and final pathway, which is the alternative pathway, this one is activated by several substances that can be found on endotoxins, or it can even be yeast cell wall carbohydrates. And what this pathway does, it utilizes a unique protein that activates the C3. Once the C3 is activated, it then leads to the C5, and thus it then goes and converges with the classical pathway. Now, what this slide does is it just gives you a visual representation of what we just discussed in the previous slide about the classical pathway, the lecithin pathway, and the alternative or pathway. So now let's talk about the second plasma protein system, the clotting system. The clotting system is a group of plasma proteins that form a blood clot made up of a network of fibrin strands. These diverse substances can activate the clotting cascade. Just like the complement cascade, the clotting cascade can be activated by multiple pathways. The pathways are known as the extrinsic pathway and the intrinsic pathway. There are also many substances that can activate the pathway. Substances such as collagen, proteinases, calcarins, and plasmin. So let's talk a little bit more about the extrinsic pathway. So how is that activated? What happens with the extrinsic pathway is that we have tissue factor, or TF. It is released and it begins to damage the epithelial cells in the blood vessels. It then reacts with factor 7 and 7A, and that is what activates that extrinsic pathway. Now let's talk about what happens with the intrinsic pathway. When we're talking about the intrinsic pathway and how it's activated, what happens is Hagman factor, which is factor 12, in the plasma, it contacts substances exposed by vascular injury. So when it does that, that is how it activates the intrinsic pathway. Now, when we look at both of these pathways, there is a common activation of both pathways with factor X. If we activate factor X, it begins in the common pathway, which leads to the activation of fibrin, and that which polymerizes and forms a fibrin clot. So we have a extrinsic pathway, and then we have an intrinsic pathway. And then both of those pathways can lead to a common pathway. Let's conclude our discussion of the plasma protein systems with the kinin systems. The kinin system interacts closely with the coagulation system. So when you're thinking about the kinin system, it also is initiated through the activation of the Hagman factor or factor 12. And that initiation of factor 12 then activates factor 12A. The final product that is produced from the kinin system is the bradykinins. And bradykinins are what is necessary or what causes the dilation of blood vessels. It also acts with prostaglandins to induce pain, causes smooth muscle contraction, and increases vascular permeability. I have included this slide because I just think it's a good visual for you all to see how the plasma protein systems can kind of coexist and intertwine with each other. If you want to get more of the details related to this, please refer to your textbook that has more detailed explanations about the intertwining of the plasma protein systems. Now we're going to transition from talking about the vascular response to inflammation to talking about cellular mediators of inflammation. Now, when we're talking specifically about different types of cellular mediators, we have some cellular mediators that are on the surface, or there are cellular receptors, such as our toll-like receptors and our PAMPs. And then we also have those that are our inflammatory response mediators. These are the ones that are initiated when we have some type of tissue injury. We are now going to talk about some specific cellular mediators of inflammation, the chemokinins and the cytokinins. All those cytokine proteins can be produced by many types of cells, such as epithelial cells, endothelial cells, or they are primarily activated by lymphocytes and macrophages. They are also able to play a role in both acute and chronic inflammation. When we talk about the cytokines, TNF and IL-1 are the two major cytokines that mediate inflammation, which are activated primarily by the macrophages. And what these two proteins do is that they are most important in the inflammation process because they affect the endothelium, the leukocytes, the fibroblasts, and induction of systemic acute phase reactions. Chemokinins are a family of small proteins that act primarily as chemoattractants for a specific type of leukocytes. There are more than 40 different types of chemokinins. However, they have 20 different receptors for these chemokinins that have been identified. Chemokinins mediate their activities by binding to those 7 transmembrane G protein coupled receptors. Certain chemokinins, such as the CXCR4 and the CCR5, act as co-receptors for a viral envelope glycoprotein for the human immunodeficiency virus HIV-1 and are therefore involved in binding and the entry of the virus into the cells. I want you to remember that there are two main functions for chemokines. One is that they stimulate leukocyte recruitment and inflammation, and they control the normal migration of cells through the various tissues. Mast cells are probably one of the most important cellular activators in the inflammatory response. Mast cells do several things when we talk about the inflammatory response. It takes part in degranulation, and it also takes part in synthesis of mediators. And we're going to talk about that in the next few slides. So what is the process that occurs with mast cells and degranulation? This process first does not start until mast cells are stimulated. Once the mast cells are stimulated, then we get a release of the mast cell granules. These granules consist of histamine, eosinophil chemotactic factor of anaphylaxis, and the cytokines TNF and 1-IL-4. Once these are released, and this release happens within seconds, then we will get an immediate effect from the release of these factors. And so when we talk about histamine specifically, which is very potent, what histamine does is it causes the temporary constriction of smooth muscle, and it also causes dilation of the postcapillary venules, and both of which will result in an increased blood flow and microcirculation. And when that happens, we will get increased vascular permeability, which will result in a retraction of the endothelial lining and the capillaries. And this will cause increased adherence to leukocytes, adherence of leukocytes to the endothelium. So that's how the histamine impacts degranulation. Now let's think about this clinically or pharmacologically as practitioners. So when we talk about histamine receptors target certain cells. The two main histamine receptors that we have is H1 and H2. Now, they have identified H3 and H4, but our main are H1 and H2. H1 receptor is pro-inflammatory, and you can find that in the lungs. H2 is anti-inflammatory, which will result in suppression of leukocyte functions. So when we think about H1 and pro-inflammatory, right, on the smooth muscle, then you think about the bronchioles, right? So you get bronchial constriction. So think about those individuals with bronchitis or if they're having an asthma flare up. And then when you think about H2, think about your gut. Think about the GERD, the gastritis, the ulcers. So if H2 receptors will secrete gastric acid, what we want to do, think about when we give a patient an H2 blocker, we reduce the gastric acid production. Thus, we can change the environment in the gut and reduce some of the symptoms that they have. That's why we treat things like GERD and ulcers with H2 blockers. And so that's how you can apply what occurs with mast cells, not only in the science arena, but think about it as clinicians. Now let's talk about the chemotactic factors that play a role in mast cell degranulation. These chemotactic factors are neutrophil chemotactic factor, also known as NCF, and we also have eosinophil chemotactic factor of anaphylaxis, ECF. What I want you to note here is that neutrophils, the NCF, are the predominant leukocytes at work during the early phase of acute inflammation. And the eosinophils have several functions in this process. So now let's talk about mast cell synthesis of mediators. I'm going to start by talking about leukotrienes, which are acidic sulfur-containing lipids that are produced by lipooxygenase. Now, what we know about leukotrienes is that they have similar effects as histamine. The effects that are similar is that leukotrienes will cause smooth muscle contraction, increased vascular permeability, and even some neutrophil and eosinophil chemotaxis. Now, let's talk a little bit about the prostaglandins. Now, these are long chain unsaturated fatty acids. And what we know is that these fatty acids are produced by arachidonic acid by the action of the enzyme cyclooxygenase, also known as COX. We classify them into different groups, groups such as prostaglandins E, D, A, F, and B. And this classification occurs because of their structure. And what we know about prostaglandins, they can inhibit some aspects of inflammation, suppressing both the release of histamine and mast cells and the release of lysosome enzymes. Now, clinically, prostaglandins are well known because of the COX-1 and COX-2 inhibitors that we prescribe for patients, our aspirins and our NSAIDs, non-steroidal anti-inflammatory drugs. What we know about the COX-1 and COX-2 is that there are complications that can occur from COX-1 when we prescribe those medications. So we can get GI toxicity or upset. So now as clinicians and as providers, we often try to choose a COX-2 selective medication that has less of a GI toxicity or upset. Now, when we talk about platelet activating factor, it's just important to note that the platelet activating factor, that it literally has very similar effects as the leukotrienes. These next few slides, slides 31 through 42, are slides that give you information and definitions about certain components important in the inflammation process. I am not going to read these slides for you, but I wanted you to have this information because these slides are important to understanding the inflammation process. If you read the slides and you need further enlightenment or further knowledge regarding the information on the slides, please refer to your textbook that can give you a lot more in-depth knowledge if necessary. These next few slides is a summation of the previous slides. It's kind of giving you a picture of what are the clinical manifestations that will be seen in patients who have local inflammation. Also helping to explain what actually is occurring in the process, summing it up into general terms. So one of the first things that's important to note is that there are some clinical signs that can be seen or manifestations that will be apparent on your patient who presents with a local inflammation. Next, the functions that are actually occurring because of inflammation. What is the purpose of inflammation? One, it's to dilute the toxins. We want to carry the plasma proteins and leukocytes to the injuring site, And then we want to be able to carry the bacterial toxins and the debris away from the site. And so when we see, if you have a patient who presents with any type of exudative fluid, what does that fluid tell you? And so on this slide, we have definitions of how we describe what that fluid or that exudate looks like and what does it indicate for the patient. Now let's move from local manifestations of inflammation to systemic manifestations of inflammation. So if you have a patient who presents to you with systemic manifestation of inflammation, we may see a fever, they may have leukocytosis, and increased plasma protein synthesis. So think about fever, and it shows you what are those causes of those fevers. So sometimes a fever is a good thing because it tells us that something is out of balance. There is some dis-ease occurring. And then we may have leukocytosis. So when you think about clinically, if you draw labs, we call it a shift to the left, which means we have an increase in the immature cells, the bands, the white blood cells. Then you also have increased plasma protein synthesis. So you think about the labs that you may draw to assess if you think that there is a systemic manifestation of inflammation that needs to be evaluated. I would like to now conclude our discussion of inflammation with discussing chronic inflammation. We have summarized what is inflammation. We talked about local inflammation. We talked about systemic inflammation. And now we're going to talk about chronic inflammation. Chronic inflammation is totally diagnosed or defined as such based off of time and time alone, 2 weeks or longer. Chronic inflammation can be the result of an unsuccessful treatment of an acute inflammatory response, or it can just be a direct process that has occurred. So when you think about a acute process that was unsuccessfully treated, you can think about things like getting a piece of glass wedged in your hand or your leg, and the piece of glass stays embedded in your skin so that infection is not taken care of, that inflammation is not completely treated. Or you can think about the treatment of diseases like syphilis, or you can have chronic inflammation that occurs not based off of an acute infection, something like a new exposure to TB, anything of that nature, a new disease process that may go unrecognized until you go in for treatment or you have symptoms. When we talk about characteristics of chronic inflammation, this is when we're talking about macrophages that are unable to limit the tissue damage related to the infection. So thus the body tries to wall off or isolate that infection, and they can form granulomas. Sometimes those granuloma formations can become large, and the macrophages are unable to phagocytize that bacteria. And when that happens, we can get epithelioid cells that begin to form. And then we can get macrophages that begin to fuse together so they are multinucleated, and we call those giant cells. Now, it is important to note that giant cells and epithelioid cells, these two special types of cells, they can form in the center of a granuloma, and then they will be surrounded by lymphocytes. And we will often be able to see that, like on a stain, you'll see that looking like an encapsulated fibrous deposit. So that's when you think about the chronic inflammation and some of the things that we see related to chronic inflammation. We will now transition from inflammation to talk a little bit about wound healing. When we talk about wound healing, it is important to be able to distinguish the terminology that is utilized to describe the healing process. When we talk about regeneration, we're talking about replacing the damaged tissue with healthy tissue. When we talk about resolution, we're talking about that tissue being resolved to its original state in a time frame of about 2 years. Not every injury, every wound can get to a state of regeneration and total resolution because the damage could be so extensive. However, you can still get repair, which means we kind of replace the wound with destroyed tissue. So we have like scar tissue, and that's what we call repair. And then that scar tissue, which is primarily filled with the collagen from the damaged tissue. So it's important to note regeneration when we want to get back to a complete state of healing, resolution, which can take up to 2 years, and then you have repair, where the tissue was damaged so severely that the tissue cannot go back to its complete original state. However, there's a form of scars, which is built off of collagen tissue, which will help the healing process and will allow you to have wound healing. So, what is the process of wound healing? So, wound healing begins first by the wound filling. Then we have the epithelialization of that wound. And then we have the contraction of that wound. So you have the filling of the wound, the sealing of the wound, and then you have the shrinking of that wound. There are 3 phases that occur with wound healing. We have phase 1, which is inflammation, phase 2, proliferation and new tissue formation, and then we have phase 3, which is remodeling and maturation. These slides are present for you in this lecture. However, please go to your textbook and read pages 212 through 214. I am not going to read the slides for you, but if you have any deficit in your knowledge after reading the slides, please refer to your textbook for more details about the phases of wound healing. Now that you've reviewed the 3 phases of wound healing, I want you to note that there are many or several causes that can contribute to dysfunctional wound healing. I want you to think about like the elderly population who, one, may not have a good nutritional intake, so they will have reduced protein, which can limit the ability for them to heal efficiently and effectively. We also have things like hypovolemia or medications that slow down the healing process. Think about medications that may reduce circulation to the area that may have a wound, like vasoconstrictors. Or you can think about individuals who have wounds where there's still infection on the inner aspect, so the wound will not heal well because of that infection. So just make note that not everyone goes through the 3 phases of wound healing and have effective wound healing, but there are some causes for dysfunctional wound healing. When we're talking about dysfunctional wound healing, it's also good to note that as you think about the diverse stages, the 3 stages of wound healing, dysfunction can occur in any one of those stages, any place in that process. And depending on which stage you have the dysfunction, you could see manifestations of the dysfunctional wound healing present differently in your patient. And here is a picture where you can see a individual who developed keloids. Keloids is where you get scar tissue formation where there was a wound, and it starts to proliferate like you see here. And keloids are also common in African Americans. Now, when we're talking about dysfunction and wound healing related to disruption, think about wounds that may dehisce or come apart. They can come apart at the suture lines. They can come back when we're using things like the liquid Band-Aids. And so that can lead to dysfunctional wound healing. It can also lead to the need for that patient to go back in and either have the wound site irrigated or IND'd and then re-closed again. Normally, if there is a disruption in the wound related to sutures, it normally will happen within 5 to 12 days. And what we will normally see is you'll get that serous drainage, or they'll tell you, patients will say, I feel like there's a pulling that's going on. Oftentimes, they're going to need some type of intervention again, if it's going back into surgery or it's taking the sutures out, cleaning out the site, and then re-stitching the patient up. In the next 2 slides, I just wanted to give you a brief synopsis of some of the differences we see in special populations. The first one is, what does innate immunity look like in the pediatric patient? So it's important as practitioners that we recognize that pediatric patients have deficits that in certain areas in their immune system. And thus we need to be cognizant of those deficits and be more astute in our assessment of these patients. So it is also important that we also look at the special population of the older adult and what does their innate immunity look like. Oftentimes in this population, we will see either impaired or delayed inflammation as a result of not only chronic diseases that these patients may have, but also the polypharmacy, the multiple medications that they may be taking that may reduce their ability to heal. And then this is also a population that may experience more commonly certain infections of the lungs, the skin, and things of that nature. So it is imperative that not only do we have a good understanding of the adult population and the innate immunity, but the special populations as well. Now, this concludes my lecture on innate immunity, and thank you so much.